سيشن باذن الله. طبعا احنا يعني بيشرفنا النهارده ان احنا نكون في يعني وحده الهيباتوبيليري سيرجري، نتكلم فيها عن موضوعات باذن الله تبقى مفيده للجميع. And we are very pleased to have the Chinese team with us, Dr. Jan, Dr. Yu, Dr. Lu, Dr. Wei,
and
Dr. Lee.
Yes,
Yes,
it's all right.
And of course, I'm very pleased to have the ex-chief of all our university, Ain Shams University, and my dear friend, Professor Dr. Mahmoud Metini, and he is one. He's a great and international hepato-pancreatic biliary surgeon, and at the same time, he's one of the founding of liver transplantation in Egypt, and I think he is the pioneer now for most of the cases. Thank you, Dr. Mahmoud, and we have a pleasure to have you here with us to introduce your lecture, if you please.
Thank you, Sham, very much for the nice introduction, and I'm very pleased to be always in Ain Shams University and ASU Medical Congress, that I think now is becoming year after year more successful after all what we've done, transforming it into a really educational whole week. So that's really gives me a great pleasure, and I'm really very passionate about and waiting for this Congress year after year. First of all, I would like to welcome all our friends from China, dear colleagues, and we're looking forward for a very fruitful collaboration together between our surgical unit and all of you with the different specialties. Especially, maybe we'll need really your help in the minimally invasive LDLT that we just started in the laparoscopic for the donor. Very slow steps, maybe not yet the robotics, so maybe we'll need your expertise here in the very near future. I'm going to share with you today our experience over the last 24 years now. We are approaching a quarter of a century very soon. By the end of next year, we started back in 2001, the program of LDLT in our country. And as we all know, it's become the standard of care for patients with end-stage liver disease, with results that is at least as good as that we received in the cadaveric program. And I'm sure our Chinese friends have got both the cadaveric and the LDLT program, maybe in your country. So now it's really yielding the same results. Donor safety in this procedure is crucial, and it remains a highly demanding technical complex surgery. Whatever we are trained, the huge experience, still challenges do arrive every now and then. With vascular and biliary anatomical variation are so common, that is the reason behind the challenges, that we usually consider these variations as a common finding. Ensuring a successful outcome is multifactorial, based on careful preoperative planning, prudent surgical anesthetic techniques, appreciating any intraoperative technical challenge that could come along, as well as the physiology of the flow modulation. It's not only technical, we have to understand the physiology of the liver, how to modulate the inflow and the outflow to guard against any graft failure. This is our experience over the years. As you can see, we bypass, we are approaching now 1,600 cases. We started in Wadi Nil, then we shifted to Ain Shams, and a smaller program in Egypt Air that is now actually is not continuing. So mainly now it's Ain Shams University taking the lead, and Wadi Nil maybe as a second option. And this is our numbers year by year. Of course, you can see the decline that happened in 2021. This is the COVID impact. As you all know, we stopped our program for 4 or 5 months. I'm not sure it was the right decision, but that was the decision for elective surgery everywhere. And then we picked up a little bit, and now I think we're going to reach very soon our same number. Our global outcome in the 20 years, of course, it differs the outcome according to the etiology and the pathology that we are transplanting for. But globally speaking, our 1-year survival is a little bit below 90%, 5 years around 72%, and with 20 years now we have patients that have been transplanted more than 20 years with more than 40% survival. Today we're going to speak about the challenges, and this is my agenda. We're going to tackle these points very rapidly: skin incision, the different veins and arteries, and the bile ducts. Skin incision. We started back in the day by the famous Mercedes-Benz incision, as you can see in the upper right-hand panel. And then we shifted after maybe 3 or 4 years to the hockey stick, which is a midline with only right. And we stayed for this tack with 16 years. And over the last 5 to 6 years, we started to omit the midline and to do only a right subpostal incision. So slowly, it's not slowly, over years, we went down the line to decrease the incision. And now it's both for donor and recipient only right subpostal. We just started the laparoscopic program for the donor hepatectomy, Hani, Baha, and all the rest of the team, and with my dear friend, Professor Olivier Sobran from Paris. And we did 3 cases only, so that's why I'm asking please the Chinese colleagues to give us a hand in this in the future. And we're aspiring, of course, the robotic donor hepatectomy, but we don't have a robot. We have a CMR, which is not very good for the HPV. We don't have a da Vinci, and we are struggling to have it very soon. How can we avoid torrential hemorrhage in the recipient and in the recipient surgery? This is usually by, as you can see, by transit portocaval shunt. We do usually transit portocaval shunt. If the hepatectomy is difficult, severe portal hypertension, we are anticipating severe hemorrhage. And this really allows early portal division, making hepatectomy easier, decreasing the intestinal congestion, and maintaining the hemodynamic stability all through this difficult surgery. Hepatic veins, the upper right-hand side panel is the best anatomy that we can receive. Is the best anatomy that we can receive. So now لازم استعمل الثاني لأنه مش عارف. من only 7 minutes maybe I'll miss some time. This is the upper the ideal anatomy. It's not in all cases. And the lower panel showed you the difficult anatomy with the dominant middle hepatic vein, V5, V8, V7, multiple outlets. So when we are faced with this, we usually used to refuse this difficult anatomy at the beginning of our experience. Now we don't have this luxury. We have to accept all kinds of donors so long it's feasible. So we reconstruct any accessory vein, V5, V6, V8, or multiple single. Any types of grafts in the absence of a cadaveric program, we have to accept this difficult anatomy. And sometimes we use either recipient portal vein or the internal jugular vein of the recipient, or even sometimes a synthetic graft. As you can see here, this is both. This is the right in the middle, and we did it in around 50 cases only. At the beginning of the experience, the Hong Kong technique, taking the middle and the right for the recipient side and keeping the left only with a left hepatic vein in the donor side. We believe, although Hong Kong it's the best results, but we believe it's maybe hazardous for the donor, so we omitted this technique and we reverted to that we take any V5 or V8, constructing, as you can see, what we call the synthetic or the artificial middle hepatic vein by end to side between V5 and V8 and this synthetic graft, and all in one channel into the middle hepatic vein. Single anastomosis of we can make 2 separate anastomosis, V5 and V8, and we can use in a reverse manner the aortic graft for V5 and V8 by the 2 limbs and the common trunk into the middle hepatic vein. This is another technique to use. This happened one side. I was not there. Fortunately, it was Muhammad Fath and Muhammad Baha, maybe. And after finishing everything, they found that the V8 was very much congested and about to burst. So they realized that there was a V8 that was overlooked and closed during the hepatectomy side in the donor. So they open it after revascularization, the grafting and the implantation is finished. And through using this synthetic graft, the Foley's catheter, to try to remove any thrombus in the V8 and the re-anastomosis it at the end after finishing all the anastomosis. So this is one technique to save a little bit of the graft and not to lose the segment A. But Paris syndrome is always a big challenge. And this is following tips and removal of the stent from the right hepatic to the right portal vein. And usually we have a vena cava that is very much attenuated and atretic, and it's a difficult surgery with a lot of bleeding sometimes. When we come to the portal vein, this is the normal variation. It's 4 types according to Shank classification. Of course, type 1 and 2 are very friendly for us to do it, and type 3 and 4 with a separate right anterior, right posterior, either with a big space or we used at the beginning also, been 10 or 15 years, to accept only type 1 and 2 and to refuse always type 3 and 4 because we're always concerned about the donor safety. But nowadays we accept any type of them. So grade 3 or 4 were contraindicated, as I said at the beginning. Now we took all of them. And maybe type 4, fortunately, we don't have it much, only 1 or 2 cases, because it could be of a hazard to the donor. And here you can see in the down panel that in the recipient side we have a right anterior. We do 2 anastomoses, the right anterior with the left hepatic vein and the right posterior with the right hepatic vein, or we can connect it to them together by the Y shape of the recipient portal vein that we on the back table we harvested and use it to make a common trunk with single anastomosis. So this is our data that 94% were only the type 2 to 1, and 5% were trifurcated, 1% were quadrifurcated. And actually, we didn't find any difference in the donor outcome when we used more difficult cases. According to Yerder, this is the portal vein thrombosis, anywhere between type 2, 1 and 4. Of course, type 4 was usually rejected because it's thrombosis of the whole splanchnic tree, and this may be needed intestinal liver transplant in the cadaveric setting that we don't have. But to be honest, we use now to accept some of these cases. What we do for the portal vein thrombosis, I'll show you our results in the portal vein thrombosis cases, where this is 90% of the cases. Eversion, thrombo, and venectomy in the technique that's shown in the panel. We hold the portal vein by 3 small mosquitoes, and we grab the thrombus from inside out slowly until we have a good flow, and then we make our anastomosis. Again, the eversion, thrombo, and venectomy. Our group, with the lead of Muhammad Fathi and Muhammad Baha, they, I would say invent, but propose a technique, then said, I usually put the portal vein clamp and keep it open, and then I accept some bleeding. They don't want this bleeding, so they use the middle finger of the assistant or of the surgeon himself, and remove the clamp at all to do this thrombectomy, and it works very good in their hands. Another thing is sometimes we cannot find the portal vein any flow, so we use any coronary vein or any large unnamed collateral, and we did this in several cases, as you can see. And it's not the splanchnic flow goes into the liver not through the portal vein, but through this unnamed portal vein, a big collateral. The third option is to use a venous from the recipient, or an artificial jump graft anywhere between the, as you can see, either the inferior mesenteric vein or the superior mesenteric distal to the thrombus. And sometimes we do, as we all know, there are sometimes spontaneous splenorenal shunt, and all the venous blood goes to the renal vein. So if you cannot find any inflow, we go to the left renal and do renoportal anastomosis. This is just to show you that it's possible, but we did the 2 of these cases, portocaval hemitransposition, when we didn't have any flow from the splanchnic side, and these patients are very bad, and usually they don't do it and they die. Now, if we finish the portal anastomosis and find there is sort of steel because of the collaterals and the spontaneous splenorenal shunt, we have to ligate the big collaterals, as you can see here, or to ligate the left renal vein to make any shunted blood go back into the splanchnic circulation and go to the portal flow and into the liver for the hepatotrophic factors coming from the gut. This is our result in the portal vein thrombosis. We're approaching 150 cases with all grades from 1 to 4. Type 4 only done in patients who are advanced end-stage liver disease, young, fit, no comorbidity, of course with some inferior results. And this is the techniques that we use in the majority of cases: eversion and thrombectomy, jump graft in 10 cases, inflow collateral in 6 cases. Artery, there is never a problem for the artery. Whenever you have 1, 2 arteries, we can do 1 or 2 or both of them, and you have a good backflow. Sometimes we and we are sure that the 2 sectors, anterior and posterior sectors, are vascularized, but single artery, we can close the other. And on the right side, this is a single case for us of that we transplanted in emergency case after on the 3rd day hepatic artery thrombosis, and we prepared a donor in 24 hours and we retransplanted. We didn't find any arteries, so we used the left gastric artery successfully. If we have absent jet flow from the right and left hepatic artery, we go down to the common. Again, we have sort of dissection. What is the causes of this? It's usually rough handling during dissection, previous multiple tests, intimal dissection. And to avoid this, we never use now. At the beginning, we always tied the hepatic artery. We stopped this 10 years ago. We dissected very carefully, gently, and put just bulldogs and cut with no ligation at all. And if it happens, this dissection, the solution is either to fixate it to the intima or use an alternative splenic artery. You can see this beautiful splenic artery dissected all through until the spleen and reverse, replacing the hepatic artery. In cases of late hepatic artery thrombosis, usually it's medical treatment, it's not surgical. But this is a case that only the right anterior sectorial intrahepatic artery had the problem, and we had biliary abscess in segment 8, so we did a segmentectomy 8, and we saved 5, 6, and 7, and this patient survived well after 1 month. This is our vascular complication in the whole series. We have a HAT around 1.6%, and as I told you early, the solution is always surgical. Late HAT, the solution is always medical. And we have 1.3% portal vein thrombosis, which retransplanted single case, and I think went through with anticoagulation for quite some time. Hepatic vein stenosis in the minority of cases. I would say this is the least complication we make. Biliary, we usually do intraoperative cholangio 3 times at the beginning to eliminate the anatomy, single right, double right, 3 rights, or whatever. And then we do it just after the resection, before the transection of the duct, to mark the line of transection with a clamp or with any marker. And at the end of the resection, we do the third cholangiography to be sure that the left or the right or whatever remaining is sound and with no leak or no injury at all. So we have 2 ducts, 3 ducts, and this is our data. 53% we had a fortunate, very easy 1 duct. More difficult, 44%, which is again usual, double duct, but we had sometimes 3 and 4 ducts, which are really challenging. This is our complication rate. We have the highest complication rate within our complication. And as we all know, biliary complication is the Achilles heel of the LDLT. So around the globe, it's somewhere between 20 and 30, and ranging from simple leakage that will stop alone up to strictures that needs multiple ERCP. We try to avoid always surgery. So we stick to ERCP. We have very world-class endoscopists that we do ERCP, dilatation, stenting. Sometimes we reach 6, 7, 8 times of repeated ERCP and stenting over years, and before we can take a decision to surgery. If failed, we try to PTC with the rendezvous technique, and we did at least 10 cases now. We have recent 2 cases not added. Surgical reconstruction successfully around 4% of the cases. Left lobe graft in the adult context are approaching 50 cases. When we do this, if the donor is relatively large left lobe, the graft recipient weight ratio that could be more than 0.6% to 0.7%, and if we have complicated right liver graft anatomy that we want to avoid the right liver graft. But at the same time, we must take decision about the recipient should be lightweight. We cannot. So in China, where the weight obesity is not as common as in Egypt, it will be easier. But really something 60 kilos, 65 kilos. We don't do this for 80 or 90 kilos plus. Child Turk classification AB, not a very sick patient, with a low MELD, around 14, 12, 11 in HCC or so, but not a high MELD, not a very sick patient, relatively good. And we do all maneuvers to decrease the portal flow. By what? Pharmacologically, as you can see, to avoid the small forsyth syndrome. So we'll modulate the intra and post-operative portal vein pressure to be always less than 15. If we find it anywhere above 15, and this is the pressure, not the flow, we must start pharmacological approaches by teriparatide this dose, and we go on into the sandostatin or the ectoriotide for the first 4, 5, 6 days in the post-operative. Sometimes we need to ligate the splenic artery, and in around 14 or 15 cases, they did this splenectomy. I don't approve it. They approve it. My team approve it, but I try to avoid the splenectomy because I think we add a potential complication for this patient after all this procedure to do splenectomy. I know it's published, but I prefer to do a splenic artery ligation with pharmacological approaches and keep the splenectomy decision to the very end. So in conclusion, how to expand the donor pool? There are some medical and some surgical maneuvers that we do to expand the donor pool to give as much as possible opportunity for our patients in the absence of a cataphilic program. We at the beginning used to refuse the hepatitis B core antibody. Now we accepted core positive to core positive. Donor with heterologous, any mutation in factor 5, any aberrance from normal, we used to refuse it for fear of post-operative thrombotic complication that could be up to 80% versus the normal non-mutation factor 5. But now, knowing that it's only around 20%, we accept the heterozygous factor and don't accept only the homozygous. Graft recipient ratio less than 0.8%. If we do it, if the donor biopsy is excellent, if the recipient is not very sick, in cases of esophageal carcinoma with acceptable condition of the patient, portal inflow manipulation, as I said, splenectomy, splenic artery ligation, pharmacological portal flow reduction, the one I mentioned. We maximize the outflow. By this, I mean that we don't leave any vein for the outflow, V8, V5, middle hepatic, so that we are sure that we're not losing even 1 cubic centimeter of this graft, with good inflow and good outflow with very good functioning graft. And I told you about that we use this hepatic veins and the trifurcated portal vein. And at the beginning also we refused any thing above 2 right ducts. Now we accept all right ducts. To conclude that, I would say it's fair to state this, that NCHAMS became really a know-how hub for LDLT in Egypt and in the region. And we outreach to any university in Egypt that would like to ask our help, as I'm asking now your help from our Chinese colleagues. So we helped Mansoura to beginning some 20 years ago, and then we helped Asyut some 10 years ago, and now we're still going to Alexandria University. But we are stick to universities, actually. Not only this, but we have some incubation within our team, like Hani, like Am, who were really incubated and took all the experience, and then they went into some private or Air Force hospital or whatever to build up their team. So it's good that we became a know-how hub with incubators and creating talents who are capable of creating new programs elsewhere in the country to serve more patients. I would like to end by thanking the whole team of NCHAMS University, surgical, medical assistants, technology, the nursing staff are really doing a great job, and of course the higher administration of NCHAMS University and the hospital. Thank you very much.
Thanks a lot, Dr. Mahmoud. I think it was a very complicated lecture, and see how it is very difficult to work in this team. Any question? Okay.
No question then. No
It's a great honor for me to present Professor Jan. Professor Jan is the Chief Surgeon, Professor of General Surgery, and the Director of the Department of General Surgery, and Director of the Pancreatic Center of the first affiliated hospital of Nanjing Medical University. He will discuss a very important subject about the surgery after introduction therapy in locally advanced pancreatic cancer.
Thank you for your introduction. Good afternoon, ladies and gentlemen, dear colleagues in Egypt. It's my great honor to be here, and I would like to thank the organizing committee for the invitation. I'm very happy to share our experience in surgical resection following neoadjuvant chemotherapy for locally advanced pancreatic cancer. As we all know, the pancreatic cancer remains one of the greatest challenges in oncology. Surgical resections combined with systemic chemotherapy significantly improve survival, but about 1/3 of patients lose the chance for surgery due to major vascular invasion. As we all know, the pancreatic cancer remains one of the great A study from Johns Hopkins showed the patients who underwent surgical resection after neoadjuvant chemotherapy had a median survival of 35 months, significantly longer than 16 months that in non-resected cases. And in both Conquer and NeoLab trials, surgical resection following neoadjuvant chemotherapy showed significantly improved the prognosis of patients with locally advanced disease. In our center, we started neoadjuvant chemotherapy in locally advanced cases since the year 2020. Here are two videos to show our surgical technique. The first one is modified ApoB procedure. This is a 7-year-old female diagnosed as pancreatic cancer with CA and CH encasement. And she received Rivox for 4 cycles. CA99 was within normal range and the tumor shrinked. The metastasis was observed on PET-MR. And the tumor response was partial response. And here we can see the tumor became smaller after chemotherapy. However, the abutment of CA was still existed. And peri-arterial divestment at SMA or first carry-out with ultrasound scalpel. Subadventitial divestment at the hepatic artery was performed, and the pancreas was resected. And then we divided CHA and the splenic vein and the conference. The lateral side of polyp was closed with running suture. And celiac axis was dissected and divided at its root. And here is the view of surgical field. And after an block resection, we can see SMA right replaced hepatic artery and KHA, GDA left renal artery, portal vein, SMV, etc. Operation time was about 4 hours. The patient suffered grade B, POPF, and grade C DGE, and finally discharged 34 days operatively. The pathology showed PDAC, R0 resection, and no positive lymph nodes. And the second one is WIP procedure. A 55 years old female of old male patient diagnosed as pancreatic cancer. And 6 cycles of Rivox were given before the surgery, and the CA99 was normalized. The tumor shrank rapidly. No metastasis observed by PET-MR. Partial response due to RECIST criteria. CT scan shows tumor shrinkage, and SMA encasement was relieved. And we performed SMA first approach to evaluate the resectability. And then SMA subadventitial divestment was performed with ultrasound scalpel and scissors. And through this approach, we dissected SMA 306 degrees from distal to proximal part for about 10 centimeters. This is SMA, middle column artery. And then CHA and CA subadventitial divestment and Heidelberg triangle ablation was performed. And here is the view after resection. We can see vena cava, portal vein, SMV, LGV, SMV, CHA, and PHA, etc. And the operation time was about 5 hours, but loss was about 300 milliliter. No complication occurred, and patients was discharged on POD 11 pathology. PDAC and zero resection was achieved, and there was no lymph node metastasis. We performed a retrospective analysis based on the total of 181 locally advanced pancreatic cancer patients received neoadjuvant chemotherapy at our center. Among them, 42 patients received radical intention resection. For regimens used in neoadjuvant chemotherapy, 11 patients received 5 FU-based regimen, 24 were treated with gemcitabine-based regimens, and 7 received combination therapies. A total of 18 patients received pancreatic duodenectomy and 20 distal pancreatectomy and 4 total pancreatectomy. And for all the patients, median operation time was 335 minutes, but loss was about 300 millimeters, and venous resection was 33%, arterial resection was 31%, subadventitial divestment 76%, arterial resection rate was 60%, and R1 resection was 40%. All R1 were R1 1 millimeters, no R1 derived cases. The overall post-operative complication was 55%, with 21 classified as Clavin-Dinder grade 3 or higher. There was no grade C POPF, and B POPF was 29%. PPH was 7%, and 90 days mortality was 2%. 20 cases were distal pancreatectomy. And here are some intraoperative images: the distal pancreatectomy with ramps procedure and the triangle operation. And these photos show the cases of modified Applebee's procedures and triangle operation with partial alternative process resection. And modified Appleby procedure combined with portal-vein resection and repair with patch. And modified Appleby with number 16 lymph node resection. Because number 16 lymph node metastasis before chemotherapy. The operative details show that the rate of ramps and the modified Appleby procedures were notably high. The R0 resection rate was 60%, and with R1 resection rate was 40%. The overall complication rate was 65%, with 15 classified with Clavin-Dinder grade 3 or higher in DP group. The incidence of POPF was 45%. 18 patients underwent pancreatic duodenectomy. Here are some images of lady with subadventitial divestment and triangle operation. The operative detail indicated that the intraoperative risks were under control. The R0 resection rate was 61%, while the R1 resection rate was 39%. The overall complication rate was 50%, with 33% classified as severe cases. However, one patient died at 2 days after surgery due to massive bleeding caused by a ruptured pseudoaneurysm after discharge. And 4 patients underwent TP. Here is the figure showing the figure surgically after TP combined with portal-vein resection. All patients with TB underwent combined venous resection and sub-adventitial divestment. 2 patients had R0 resection, while the other had R1 resection. One patient experienced post-operative hemorrhage, no reoperation, and no death within 19 days. Let's look at the survival outcome for all the resected patients. There was one perioperative death, and 41 patients were followed up. The 1 and 3 year survival rate was 97% and 55% retrospectively from the diagnosis. 81% and 54% from the time of surgery. For all the patients with locally advanced disease, the MOS was 21 per month and 47 months for those resected, 18 months for those wrongly resected. The survival curves indicated a significant survival benefit for resected patients. And here is the overall survival for patients with different tumor location and different type of surgery. Patients after DP had the best prognosis and have not reached up to August 2023, while patients after TB had the poorest one. There was no significant difference in survival among different regimens for neoadjuvant therapy. This held true in all patients as well as in resection and non-resection subgroups. Subgroup survival analysis revealed that patients with C99 level higher than 80 units after neoadjuvant chemotherapy and combined venous resection was associated with poorer survival. In summary, surgical significantly improved survival after neoadjuvant chemotherapy in locally advanced disease. There is a high rate of complication and the vascular resection, the sub-adventitial divestment procedures performed in resected patients, and different first-line neoadjuvant chemotherapy regimen appear to have no significant impact on survival. And total pancreatectomy, venous resection, and pre-operative serum C99 more than 80 units associated with poor prognosis in these resected patients. Our center is a disease-centered real-time MDT. In 2023, a total of 1,500 pancreatic surgeries were performed in our center, including 625 WIPS procedures. So thank you for your attention, and warm welcome to visit our center. And thank you again. Thank you for again inviting me to attend this great meeting. Thank you so much.
Can I ask a question, if you please? Because in 2 of your pictures, I found that you removed the gyrota fascia, or all the fascia around the left kidney. Why?
In this patient, because the tumor invaded the adrenal gland, so we do the posterior ramps procedure. So, yeah.
Timing after neoadjuvant and when to say now we can proceed for WIPL. For a pancreatic in a patient with a pancreatic head cancer, start locally advanced, starting neoadjuvant, showing a partial response, but the relation is still more than 180 degree in contact with the supramesenteric artery. When to say this partial response is accepted to proceed for Whipple, and this partial response not accepted, when to stop. Sometimes we are giving the new adjuvant and we have a response and proceed, but still not satisfactory, and proceed for another sessions and giving a response but still not satisfactory. When to stop? When to stop chemotherapy and say now it's the time for surgery?
Yeah, a great question. You ask the timing of the surgery. Yeah. In our center, we choose these patients who have the stable or partial or CR. This patient, and the timing at least 4 months chemotherapy, and we can achieve from the CT scan. We can do the RO at least R1 dissection.
You are accepting in your series R1 resection. In this case, in these types of patients, you are accepting R1 resection, and I think we're showing the improving the survival regarding even in patients with R1 resection.
Sorry?
How satisfactory
This
the
is-
results of R1 resection?
Oh yeah. You asked the R1 survival outcome.
Yeah.
Oh,
Yes,
I'm sorry about that because I don't remember exactly the data. After the meeting, I ask you the data. Yeah, thank you.
Thank you. In the cases, I'll go for the distal pancreatectomy first. If you have an advanced case as the one you showed, and you do this distal pancreatectomy with the left sub adrenal gland and the fascia and everything, if this is invading up to the celiac trunk, because we had this case, one case like this, do you remove the celiac trunk and the resection? And if you do this, do you re-arterialize the hepatic artery or not? Because it's very distal. Sometimes you have the gastroduodenal and more distal collaterals that you can rely on. So the first question, would you go and remove the celiac trunk, the whole thing? And if you do this, do you just resection and that's it, or some sort of reconstruction for the hepatic artery?
In most of the cases, we resect the celiac trunk. I don't do the reconstruction. Yeah, just the resect. Yeah. But if we find the low blood flow, I mean DHA, we will do the reconstruction. Yeah.
Thank you very much.
Thank you so much.
We have a pleasure to introduce Professor Dr. Mohammed Fathi, one of the pioneers of hepatobiliary pancreatic surgery again in Egypt. He will talk about difficult questions, the points of controversy in colorectal liver mets. Yes?
Thank you. Today, speaking about the colorectal liver mets, important and hot topics, I choose 10 points of debate. Definitely, there is a lot of these debates, but today you are concentrating about the surgical treatments and the debate in the choice of surgical treatment. We know that the colorectal cancer is a very important. We have about 1 million cases annually worldwide. It's the second cause of cancer-related death, and it's the commonest GIT malignancy. But for us as a liver surgeons, 2 points is very important. Half of the patients with cancer colon will develop liver metastasis. So this is an important figure. And the second is 25% of these patients will present as asynchronous metastasis, which means the colon and liver at the same time. So we have to be prepared for these patients in the management. What are the options for us for colorectal liver metastasis? First, if we do nothing, then we are speaking about 6 to 9 months survival, which is very, very bad. Second, if we depend only on the chemotherapy, we are speaking about 14 months. If we shift to local ablative therapy like RF, we are speaking about 40%, 3 years survival. But with surgery, we will find the 5-year survival, which may be up to 60%, which is a very good option in a patient with a metastatic disease. And we know that the hazards of surgery is very limited. If you look here, we are speaking about mortality from 0 to 4% at different centers. So the surgical treatments is the best way of treating these patients. The first question is, what is the resection? The classic resection margin 1 centimeter, or we can go smaller than this. Actually, a lot of studies now discussing 1 millimeter safety margin. And they found that choosing 1 millimeter safety margin, it doesn't change the overall survival of these patients. So we are now shifting down, sizing the resection margin from 1 centimeter till 1 millimeter. And even further, one of the studies discussing the R1 resection. If you have a tumor, and this tumor is beside unsacrificed structure, if we do resection, we reach R1 instead of R0, yes, definitely there is a high incidence of local recurrence. But still, this high incidence of local recurrence in the era of chemotherapy, or new agents of chemotherapy, it gives a good chance for these patients. So these patients should be discussed case by case and not rejected from the start. And if we are going to do resection, should we do anatomical resection or non-anatomical resection? 2,500 patients in different studies, they found there is no change or no benefit from going the anatomical resection in these patients as regards the survival. So we prefer to be non-anatomical to preserve liver parenchyma as much as we can. As we have just said, that we can achieve up to 60% 5-year survival. But this depends on the risk factor. And we can expect which patient will benefit from surgery and what is the expected 5-year survival, depending on some risk factors. We have a different scoring system. We don't have the gold standard scoring system, but one of the most common one is the Fung score. It has 5 risk factors. These 5 risk factors: tumor number, tumor size, the lymph node, the CAA, and the synchronicity between the tumor and the liver. If the patient has the 5 risk factors negative, you will get a 5-year survival of 40 to 60%. If they are all positive, we have about 14% 5-year survival. But this is not only the factors that determine the outcome. We have other biological factors, like the response to the chemotherapy. The patient who respond or do not respond to chemotherapy, they have a 5-year survival of 8% compared to 37% who shows partial response and 30% who are stable disease. So the response of the chemotherapy is a good indicator and is a good biological markers for these patients. The tumor genetic states, the rest, the BRAF genes, the tumor growth pattern, degrading the tumor, expression of the chemotherapy, the molecular subtypes, all of these are the biological prognostic factors, and now a lot of prognostic scoring systems are evolving to choose which patient will benefit from surgery and what is the best treatment. One of these, we call it the GAME, the genetic and morphological evaluation. It incorporates 6 risk factors, including the KRAS mutation, the CAA, the primary lymph nodes, and they shift the tumor size to tumor burden score and the extrahepatic disease. And they classify the patient into low risk, high risk, and medium risk. And this figure shows the difference between the accuracy of this GAME score in comparison to other scoring systems. And they divide the patient, like in the pancreas, into a resectable patient who could be resected surgically, unresectable patient, and borderline resectable. This borderline resection in the colorectal is one of the new era. They divide the borderline resectable into anatomically borderline or biologically borderline. So the patient can be anatomically resected, but the biological factors is unresectable. They consider him as a borderline resectable patient. And then, should we give adjuvant or neoadjuvant therapy if the patient is resectable from the start? Should we go to surgery or we go to chemotherapy and then surgery? We know that the neoadjuvant therapy has definite advantage, like we assess the natural history of the disease. It decrease the size of the tumor, so it will decrease the magnitude of surgery. It can give time for occult recesses to be appear, so we can plan the surgery right on what is the burden, the true burden of disease on the patient. But a meta-analysis including 18 studies for the neoadjuvant therapy that didn't offer progression-free survival benefit in on whole patient, but it has a benefit in a high-risk patient. So another studies on 350 patients, they found they divide the patient into low-risk patient and a high-risk patient according to the Fong score, and they found the patient in a high-risk score they benefit from neoadjuvant chemotherapy, but in the low-risk patient they didn't benefit from chemotherapy. So if you have a patient with a colorectal liver mets and he is a low-risk patient, we go to surgery first and then chemotherapy. If he is a high risk, depending on these factors, then the chemotherapy will be better. And the second question, the duration of this neoadjuvant therapy. As we know that the oncologists continue to give chemotherapy several times. When to stop the chemotherapy and just the surgery? They found, one of the studies, they found the 5 cycles or less. Beyond this, he didn't gain a benefit in the survival. And even another study showed that beyond 5 cycles, they are associated with reduced progression-free survival, even and overall survival. So we should stick to about the 5 cycles or less, not continue chemotherapy for long periods. Definitely the synchronous tumor, we have different approaches for the synchronous tumor. We have what we call the classic approach, which is the colon first approach. We remove the colon, give chemotherapy, and then the liver. Or we have the simultaneous approach, remove the colon and liver surgery at the same time. And we have the reverse approach. We can remove the liver lesions first before removing the colon. The factors determine, it depends on the symptoms of the patient, depends on the location, extent of the tumor, the primary, the secondary, the performance states of the patient themselves. And we have different approach depending on the location of the tumor in the liver and location tumor in the colon. We know that we have a lot of advantage from the simultaneous resection because we will, it's one of procedures, hospital stay is less, the cost is less, we remove all the malignant foci at the same time, so we avoid the temporary immune suppression period after surgery. There is no delay in the systemic therapy because we know that if you did a colon first and then chemotherapy, sometimes we don't reach the therapy. We do the colon surgery and then leak after colonic surgery, so the chemotherapy will be delayed. Even if a wound infection after colonic surgery, they may delay the chemotherapy. But we have a disadvantage of this simultaneous. We combine a 2 operation with a clean operation, the liver surgery, and potential infective operation, which is the colon. And we have may increase the risk of colonic leakage, because if a bleeding occur and you try to do Pringle maneuver, the Pringle will do congestion on the intestine, so it may increase the incidence of leak. And definitely the exposure of the liver surgery alone, not like liver and colon, will be at more ease if you are doing liver surgery only. And the most important is that we don't know what is the occult lesions that are not present in the CT. So we try to do what we call it the test of time. Test of time, we give the colonic surgery and stay and wait for 6 months chemotherapy to test if there is another lesion will appear. So we do 1 operation for the patients. And we have some criteria to choose the synchronous lesions depending on synchronous approach, depending on patient factor, like the age, the surgical fitness, the tumor factor of the colon, T4 is not for synchronous approach. The tumor, if there is more poor lymph nodes, if there is a histology poorly differentiated or mucinous, the liver factors, if there is 3 or more metastasis, and there must be no major resection in the liver simultaneous with the colon. And the reversed strategy from MD Anderson, and in this case, we have two things. First, the colon tumor should not be obstruction or bleeding. So you are not afraid from the colon, and the liver lesions, you are afraid. It is advanced. It's very near hepatic veins. If it gross occur, it will be irresectable. So it is designed for a selective patient who was afraid from the liver, and you're not afraid from the colon. Lastly, one of the new things is the liver transplantation for colorectal liver mets. It was previously a contraindication, but we found that it can, in selected patients, it can give some benefit in the survival. If you look here, if the patient is a non-resectable patient, the 5-year survival is 10%. But if we do a resection, according to SICA study, was done for a transplanted non-resectable colorectal liver mets, and they found that the observation period, it was 27 to 65 months, which may be 5 years. It's ranging from 60% to 56%. So we can reach a 5-year survival over 50% in patients who are not candidate for any surgical interference. And they found there is a risk factor for transplantation, like the CEA above 80 and different risk factors. If we exclude these patients with this risk factor from our study, we can find a 5-year survival of about 75%, which is near to the survival of transplanted patient according to other diseases. So, to my mind, the future liver transplantation will be directed to the colorectal liver metastasis. And this figure shows the difference in the survival in the patient with the colorectal liver mets in high risk and low risk groups. And we find that in a low risk group, the survival is close to the patient with HCC within Milan or beyond Milan. Then, if we do a resection and recurrence occur, should we do another resection? Yes, all the studies show that the survival benefit of a repeated resection is similar to that the patient with a single resection. If the patient has an extrahepatic disease, they found that lung metastasis resection with the colon, with the liver, they have the same survival like the patient with liver only. And now they are speaking about the peritoneal disease, what we call, they do with the HIPEC technique, removal of the peritoneal local resection of peritoneum with the chemotherapy. Still under debate, but it is a promising option for these advanced patients. Lastly, the disappearing metastasis, we know that if the patient have liver metastasis small and receive chemotherapy, and with this chemotherapy, this small metastasis could disappear. This disappearing metastasis, the recurrence rate is 80%. So we are afraid that this metastasis disappear. One of the options, they are trying now to do fiducia, some localization for the metastasis before starting the chemotherapy to detect the occult metastasis intraoperative later. And they found that this disappearing metastasis on radiology, in 65% of cases, they found it on the operation. So, although it is not apparent in the CT, it is present on the operation. So we can still, if we have a disappearing metastasis, go to the operation and try searching for this metastasis, because you know this is the only hope for cure of these patients. Thank you.
Thank you, Mohammed, for this very nice elaboration about the CRM. And the floor is open for any question. You don't have any question or comment on that? Let's go ahead. Can you hi? Yes.
Actually, what we don't do the marking. If we have a disappearing metastasis, either we wait till it reappear and then do a resection as classic, or if we are going for a colonic surgery and we explore the liver at the same time. If we found, and in 65% you will find the lesion, and so we will deal the lesion like the classic cases.
Yes.
Close. They give chemotherapy for this patient. In borderline sector, we said that it is maybe anatomically borderline or biologically borderline. Anatomical borderline, so I will not achieve R0. So maybe with chemotherapy, it shrinks, so can achieve the R0. If it is biologically borderline, like we have a high CAA, we have a lymph node metastasis, we have a tumor size is large, tumor number is large. With the chemotherapy, it decreases in size, so it will decrease the risk and become biologically not a borderline.
So the answer is always neoadjuvant and reassessment.
Yes.
Okay, go ahead.
We routinely do intraoperative ultrasound, and the intraoperative ultrasound may be more accurate than the CT and MRI. A lot of cases we do CT MRI found 2 lesions. With the intraoperative ultrasound, we found more lesions or less. So in this patient, we'll do an ultrasound and determine the actual extent of the disease. If it is a low-risk patient and we found a lesion in the periphery, he does not need extended surgery, we'll do resection at the same time. If you found a spreading metastasis, multiple lesions, so we postpone liver surgery after chemotherapy. الافضل to give a chance for neoadjuvant chemotherapy if we do an extensive surgery.
Mohammed, I will take the thread from the last question because you mentioned 3 techniques, colon first, the neoadjuvant first, or the liver first, or whatever. But you didn't tell us what do you prefer. You have to send some messages to the young surgeons here because now things have changed with the new chemotherapeutic agents, and the neoadjuvant are very strong. That for me, for example, I don't know I don't want to say it before you say, but I'm for neoadjuvant for all colorectal cancers before any embarkment of any surgical treatment, because the colon and the rectum have never become a problem now, even for in the bleeding context or something like that. And it's always the patient dies from the liver mets, not from the colon or the rectal cancer. So if you can elaborate on this point more and tell us what is your preference and your real life experience in this, because I think in the preparation of this Congress, it would have been much better if we put the colorectal surgery before or after the liver surgery at HPV rather than the breast, because we need our friends in the colorectal that we always work in conjunction with them. Go ahead.
Very difficult question to choose which is the best for this patient. And actually, we do in every case MDT meeting. The MDT with the oncologist, with the liver surgeon, with the colon surgeon. And case by case, we discuss. Because if you have one lesion on the left loop, peripheral lesions, it's different from the same one lesion in the center of the left loop. So I will ask first the coronary surgeon, do you think you will do a curative resection, or it may be borderline for him as a colon? If one of the important points, you never do a liver surgery if the colonic surgery is not a curative resection. Sometimes they at the pelvic floor, he said that it was a malignant adhesion, and during cutting he is not sure that he do a curative resection. In this case, I will not do any liver surgery. I give him chemotherapy first. So the decision to do simultaneous approach or metachronous approach is depend on the size of the lesion, the number of the lesions, the extent of surgery needed, the general condition of the patient, the colonic surgeon preference, the chronic surgeon experience. Different factors will determine this. The liver first approach, I did very limited cases, and I started this because I lost one patient from this. The patient has a one lesion on the right loop. It was 4 centimeters, taking the right hepatic vein and the middle hepatic vein. And the left hepatic vein is split. And he has a colonic surgery. So we decide to give him chemotherapy, then it shrinks and we can do surgery safely. Actually, it progressed on chemotherapy and invade the left hepatic vein. So the old hepatic vein now invaded by the tumor, and the patient transferred from resectable to non-resectable patient. So
This patient will never do it anyway.
yeah, I know that progression on chemotherapy is a very bad impact, but still they said that it is not a contraindication for surgery. It's a bad prognosis, but not a contraindication for surgery.
Yeah, but for the interest of time, you cannot make a general statement that all these patients should go upfront to neoadjuvant
No.
as a general rule, and then we decide later on, because this really helps in, I mean, with colorectal mets.
We have one slide. They one study. They divide the patient into low risk patient and high risk patient. And low risk patient, they take a score from 0 to 2. These patients benefit from resection, and the high risk patient from 3 to 5, they benefit from chemotherapy. So they are not. I cannot.
MD Anderson approach is only for the high risk.
For the high risk as a liver lesions,
Yeah.
not for the whole series.
Second point for the transplantation, because as you know, this is our main concern now. So any colorectal surgeon, zero, our friends from China have got any, I know that you're pancreatic surgeon, but in your center, do you do transplantation for colorectal mass, the Danish technique? And do you have any experience in this? Just from your colleagues, not from yourself. Do you do this in your center? Transplantation for colorectal mets? No, it's not yet an indication. No. Yeah. I believe it will arrive. It will not be the main indication, as you say, but it will be a rising indication beside the esophageal carcinoma and the NASH. And I think this will be the third comment. If we really work in good conjunction, good collaboration with our colorectal surgeons, oncologists, and the whole team. Thank you very much. Wonderful.
Now we'll introduce Professor Dr. Mahmoud Talat, speaking about the pediatric liver transplantation in Egypt.
السلام عليكم. Now we are talking about history of pediatric liver transplantation in Egypt. The whole story from the start. What's the meaning of organ transplant? Organ transplant is to replace the diseased organ by another healthy one. The source of this organ may be a living donor or deceased donor. According to this, it's living donor or deceased donor liver transplantation. History of organ transplantation in Boston, December 1954 by Joseph Murray. This American surgeon received the Nobel Prize in medicine in 1990. By the way, Joseph Murray was a plastic surgeon, not a transplant surgeon. The kidney was the first organ he did the transplant successfully. The first attempt to do liver transplant in the USA by Thomas Starzl in 1963. It was a successful surgery, and the patient was alive for 1 year. But the challenging point was rejection. There is, at this time, there were no immune drugs that make immune suppressive drugs. The first immune suppressive drugs was cyclosporin. Cyclosporin discovered in the 1970 from some fungi. Thomas Starzel started to use cyclosporin after approval of FDA. After cyclosporin use, this is a great evolution of the results of living donor or liver transplantation or organ transplantation in general. Success rate of 5-year survival was about 20% before cyclosporin, and after cyclosporin, now success rate was about 90%. Why we do liver transplant? In some cases, or most cases, decompensation of the liver either by acute insult or chronic insult. Acute liver failure or chronic liver failure, which termed liver cirrhosis. After liver transplantation, success rate or 5-year survival, 1-year survival was about 90. 5-year survival is about 70. In general, indications of liver transplantation: chronic liver disease, acute liver cell failure, or some cases to acute liver cell failure, metabolic disease or inborn error of metabolism, and some cases those liver tumors. In Egypt, there were a great evolution in our experience in liver transplantation. Some of our professor, Dr. Yasin Abd Ghaffar, Dr. Nagi Naguib, Dr. Medhat Khafagi, Professor Dr. Mahmoud Al-Mitini, Dr. Alaa Faiz, and Professor Dr. Rifat Kamil. Dr. Alaa Faiz, Allah yarhamu. Our center did liver transplantation, National Liver Institute, National Cancer Institute. We did the first deceased liver transplantation, 2 cases in 1992. Wadi Nil Hospital, Dar El Fuad, El Maadi, Cairo University, El Mansoura University, International Medical Center, Sahel Hospital, Egypt Air, Al Azhar, and Shams University. Total cases till 2013 is about more than 2,100. Indication of liver transplantation. Here in pediatric liver transplantation instruction, we did about 160 cases of pediatric liver transplant, and the rest of cases were adult liver transplantation. Here are statistics till 2024. Pediatric liver transplantation in November, this increase in the percentage and total number of pediatric liver transplant. In general, it was 7%. Now it's in 1994, it's 9%. Our center that did living donor liver transplant in pediatric age group: Wadi Nil Hospital, Air Force, Saudi German Hospital, Mansoura, National Liver Institute, Cairo University, and Dar el Fuad. Our team experience in Air Force Specialized Hospital. We started the program in in Air Force Specialized Hospital. The total number of pediatric and adult liver transplantation till the end of 2024 is about 700. about 25% from the total number were in pediatric age group. Here is some indications of pediatric liver transplantation and statistics in our center experience. The most common is biliary atresia and progressive familial intrahepatic cholestasis, congenital hepatic fibrosis, thyroidemia, and most of the other indication is inborn error metabolism. Some cases we transplanted some cases of hepatoblastoma. We did 3 cases of liver transplantation in pediatric age group. Gender, there were about 39% female and 61 male. The median age group is about 4.7. The youngest child we did transplant was 7 months, and maximum 18 years old. The average weight, our mean weight, is about 24 kilogram. The lowest weight we did transplant 5.3 kilogram. She was about 7 months. Here is survival outcome. In age group less than 8 years, about 80%. Survival outcome in different age group, different weight group. Sorry. Over the details in pediatric liver transplant, the graft type. Usually we use left lateral segment, segment 2 and 3, 50%. Left lobe and middle hepatic vein, 45%. Right lobe graft, only 3.6%. Mortality rate in pediatric liver transplantation. Overall, the overall 1 year survival was about 90%. In about some cases, we did transplantation in Saudi German hospital. Thank you.
Thank you, Dr. Mahmoud. Anyone have any question for Dr. Mahmoud for the pediatric liver transplantation? Okay, thank you. Thank you. This will end our session for hepatobiliary surgery. Thanks.